All right, so thank you, AIOS and the German Ophthalmology Society for letting me into this program. I'll just talk about the angle surgery for glaucoma, aventino trabectomy. I have no financial interest in any of the procedures. So glaucoma surgery, is continuously evolving, and trabeculectomy and glaucoma drainage devices are the mainstay of treatment as of now, and mostly preferred by glaucoma surgeons. But many new procedures have and devices have been introduced in the recent past, and they have shown a lot of promise in controlling intraocular pressure. As you know, there are a number of devices, and basically they seek to drain inside either through the Schlemm's canal or through the suprachoroidal space. But I'll mostly be talking about the MIGs that involve removing or incising the trabecular meshwork to expose the Schlemm's canal so that the aqueous can be drained uh, easily from through the collector channels of the Schlemm's canal. So trabeculotomy. So there are a number of procedures here where trabecular tissue is bypassed by excision of the trabecular tissue. So trabectome, Hauck's dual blade, and gonio-assisted transluminal trabeculotomy are the three procedures that they fall into this particular category. I have no personal experience with Hauck's dual blade, so I'll be talking about the trabectome and also the gonio-assisted transluminal trabeculotomy. So the trabectome, basically, it is a special probe here, and which has a specialized tip which generates, uses high frequency current to generate plasma at the tip, and with this you can ablate the trabecular tissue. The probe is designed in a way that this tip goes into the Schlemm's canal, and you can ablate the trabecular meshwork so that anterior chamber connects easily with the Schlemm's canal and through aqueous passes. So basically, you need to have a direct gonioscope to position the patient, conveniently. So you have to tilt your microscope, and this is one Jacob lens I'm using. So you have to make a small incision in the clear cornea. Use a carrot arm to make 1.2 millimeter incision, and through which you can use the trabectome tip, which is, as I said earlier, has an angled, pointed tip, which can engage into the trabecular meshwork, into the Schlemm's canal. And once that happens, you activate the probe and you sweep it across the angle in one direction, and then you can turn the probe and do in the opposite direction. And also you can change the mirror of the position a little bit. So by manipulating, turning the globe, rotating the globe a little bit, you can do about 210 degrees ablation. And mostly surgeons combine it with the phaco surgery. So if that is the case, you can go ahead and do phacoemulsification and put an intraocular lens implant. However, you could do this procedure even without intraocular lens implant. So that's it. Basically, the procedure is quite simple and straightforward in that sense, but it needs expertise with gonioscopy, and also has a learning curve. And at the end of the surgery, you can just hydrate the pores, and that basically takes care. So trabectome, if you look at the outcome, so now we don't have a lot of literature, but still there's a good amount of data is now available, and this is from the trabectome study group. So you can see that after about 1 year, it can still give you a good IOP control, almost 9.3 millimeters IOP lowering from the baseline, and when combined with the glaucoma cataract surgery, still it has a good IOP lowering in POAG as well as to the exfoliation glaucoma patients. So, and you can see this has been tried in if you look at the larger series, larger databases, basically, which we have collected now. So in this particular publication, they looked at its efficacy in reducing IOP in mild glaucoma or in moderate glaucoma, and it looks like that is effective in both of these situations. However, it is a little more effective if the glaucoma is mild and a little less as compared to in a moderate or severe disease. And the procedure has been tried in many different phenotypes of glaucoma: primary open, pseudoexfoliation, uveitis, steroid-induced pigmentary, NTG juvenile, and it seems to work in most of these situations. The other procedure we're going to talk about is the GAT, that's gonio-assisted transluminal trabeculotomy. So this can be done through an illuminated catheter or a 5-0 Prolene suture. The illuminated catheter is specially designed and it can push through the Schlemm's canal, Aventurno. And because it has an illuminated tip, so you can follow it through and you know where the probe is going. However, this is quite expensive, and 5-0 Prolene suture is very inexpensive and a much cheaper alternative to to this procedure. So using a 5-0 Prolene suture, you cauterize the end a little bit to make it bulbous and round. And once that is done, you actually create a 2-port incision. One, the main port, which is again, you can use an MVR knife. You don't need a big incision. You just MVR knife incision about 1 millimeter is enough. And also inject some pilocarpine to constrict the pupil. And then you can inject a viscoelastic to maintain the anterior chamber. And then you made another port about 90 degrees away using the MVR knife again. And lead the Prolene suture through the second port inside. Then with the gonioscopy, you inspect the angle, and with the MVR knife, you create a little opening, a little nick into the Schlemm's canal, just to give a starting point. And once your trabecular meshwork is incised, you can enter the Schlemm's canal through that point, and then using some intraocular forceps, you catch hold of that thread, that Prolene suture, and thread it through the Schlemm's canal. So we keep doing it till it reappears at the point where trabecular meshwork was incised. And once that happens, we grab it. Then we'll grab that that end. So we are waiting for it to come, and once it has come there, so now we grab that end, and now we can remove the gonioprism and pull the other end. This is going to rip the trabecular meshwork 360 degrees and connect the anterior chamber directly with the Schlemm's canal. And then you can inspect, usually the hyphema would happen in this condition we haven't noticed so far. And after that, you remove the viscoelastic and just hydrate the pores, and your procedure is basically done. So there are not many studies, good studies basically, but I looked at this meta-analysis published recently in the International Journal of Ophthalmology. They looked at 108 publications and found that 10 publications were good enough. They qualified the criteria to be included. And when they looked at the mean pooled IOP reduction, it gave out 9.8 millimeter IOP reduction combined for all these studies. And also the pooled surgical success rate, that is IOP of IOP reduction of more than 20% or IOP less than 21 millimeters of mercury with or without drugs. So pooled success rate is over 80%, 85%. And the combined for this data, the resurgery rates were 25%. So it's pretty good results actually. And there was a significant amount in the reduction of the eye drops. Was also number of eye drops used post-operative with control IOP was also seen. So these results seems to be encouraging for at least on a short to medium term follow-up. The usual complication most frequently seen is hyphema, which could see seen about in the pooled data. It was around 36%, but somewhere around in it's like 20-30%. Most of the studies you will see hyphema, which is not a much consequence. It goes away on its own, and you don't really need any intervention. Some people may experience IOP spike, and that needs to be taken care of. So we have to watch for the IOP spike in the post-operative period, and control it with anti-glaucoma drugs if that happens. So apart from that, other studies are actually, other complications are very negligible. They're low rate of complications. So GAT has been tried in different phenotypes, again, pseudo exfoliation, pigmentary uveitis, steroids, and it seems to work in most of the procedures. And as per these authors, the GAT procedure is a safe and successful option for the treatment of moderate to advanced open angle glaucoma. Surgical success could be maintained up to about 18 months in their experience. So to summarize, angle surgery for glaucoma is going to stay. A significant lowering of IOP has been reported in, with this procedure in many different phenotypes of glaucoma. Is good, has a good safety profile, and generally done with cataract surgery where it forms a good adjunct to cataract surgery. And thank you again so much for including me into this program, AIOS and the Journal of Ophthalmology Society. Thank you so much.